Hi, Jamie. How are you? Hi, Jamie. Oh, sorry.
Hi, Mercy. How are
Hi,
you?
Alex. How are you? You
Sorry
just
about
have a
that.
wonderful
I couldn't
interpretation.
unmute.
You should be able to unmute now, Alex and Jamie.
Yes, I can unmute. Thank you so much, Mercy. I'm just sending a reminder on the WhatsApp group about the meeting.
Mm,
Okay, we've done that. Okay, perfect. And then Cynthia will be joining us. She did tell me that she needs to just leave a little bit early at 4:30. And I said that should be okay.
Sorry, Jamie, you'll have to repeat what you're saying because I had forgotten that my headset was on my laptop. I wasn't using the speaker, so I did not hear anything you said.
No problem. I just said that Cynthia's gonna join us, but she'll have to leave a little bit early at about 4:30, which I said to her is okay.
All right, no worries.
Yeah.
Hi, Prof. Shabir. How are you?
Hi, Mercy. Hi, Jamie. Hi, Alexandria.
Hi. Thank you for joining, everyone. We're just going to wait for our other facilitators, Cynthia, to join us, and also a few more people. So we'll give it a couple more minutes, I think. Thank you.
Because it's still have about 15 and it was a Saturday. So a Sunday would be a good day too.
Hi, Cynthia. How are you?
Hi,
I'm
Cynthia.
fine, and how about you? Hi, how are you?
Good, thanks, and you?
Thank you. Nice to at last our meeting has taken place. You remember last time it was somehow postponed.
Yes. So Cynthia, if you're ready to start, I'm ready. I think we can begin, and then other
Okay.
people will join as we go along.
Okay.
Okay, so I'm just going to start my video for now. All right, so hi everyone. My name is Jamie Colity. I am a medical doctor from South Africa and part of the AfroPHC executive coordinating team. I'm one of the facilitators for today's South African chapter consultation for the AfroPHC, along with Cynthia, who will introduce herself now. And thank you all for being with us today. We hope that we will get some valuable inputs from everyone. So I think maybe we can just start off with some welcomes and some introductions. So maybe if Cynthia, you'd like to introduce yourself as the other facilitator for today's consultation, and then I will just go through the list and we can see who's here for today. Thanks.
This happened to my meeting now. Just went off like that.
We can see you, Cynthia.
Can you? Okay, I don't know what happened, Emma. Okay.
Yeah, we can see you.
Greetings to everybody. Yes, I'm Cynthia Chaiba from Zimbabwe. I'm a lecturer in the Department of Nursing and Midwifery Sciences. I'm also an executive board member of the AfroPHC, and together with Jamie, we are facilitators for the Southern Africa chapter of AfroPHC. Welcome, everybody. We invite you to bring valuable contributions towards developing this framework, which we are going to discuss in October in South Africa. Welcome, and we value contributions to this meeting. Thank you.
Thank you, Cynthia. And then if I could ask Prof. Shabir Musa to please introduce himself, and then I'll carry on going through the list.
Hi, everyone. My name is Shabir Musa. Sorry, I'm not in the best place to talk. I'm going to be at the background, the executive coordinator, but I'll be soon handing over to Mercy, I think who'll speak next, and then Jamie as executive coordinators going forward. Thanks.
Thank you so much, Prof. Musa. Mercy?
Good afternoon, everybody. I'm Mercy Wanjala. I'm a family physician from Kenya and the Deputy Executive Coordinator, AfroPHC. And I'm glad to be here today for the AfroPHC chapter, South African chapter consultation, and I look forward to a rich discussion and addition to the policy framework. Thank you.
Thank you so much, Mercy. Tabiso Ngwenya, you could unmute yourself and introduce yourself.
Good afternoon, ladies. I'm Tabiso Ngwenya from a lecturer at the National Science at the National University of Science and Technology in Zimbabwe. I'm glad to be part of this team.
Thank you so much, Tabiso. We are happy to have you here with us today. If I can go to Mungabo Chongo.
Hello, everyone. My name is Mungabo Chongo. I'm a medical doctor from Zambia.
Thank you so much, Mungabo, and thank you for being with us here today. Then if I can go to Dr. Izodinma. If you could unmute and introduce yourself.
Hello. Yeah. Good time, everyone. Good afternoon. Let me pay my respects to Prof. Prof, you've been great in handling us and bringing us thus far, Professor Musa. And again, I don't know, I am speaking from Nigeria, but I don't know whether I should be here. I got the invitation severally, so I joined. My name is Dr. Zadim Madrieje. I am the CEO of AfroPHC Association. I have over 20 years experience in planning and managing interventions that promote productivity, accountability, and transparency in social welfare and social safety nets, health issues, development work, sustainable development, and health. I am a health economist and professional evaluator. I'm the immediate past national president of the Nigerian Association of Evaluators. I'm an monitoring and evaluation specialist and a trainer. I provide consulting services in a whole lot of things, but typically, I am adapted to One Health. I'm a One Health champion, where we look at health from the prism of everything that affects health, be they in clinical issues, disease issues, environmental issues, energy issues, health issues, and issues about human rights, gender, and governance. It's really nice being here, and I just hope I didn't get crushed. Thank you.
No, you are welcome to join us. So today's chapter is for Southern Africa, but we still welcome everyone at these meetings. So thank you for joining us. Okay, and then if I could have next to introduce themselves, Hussein. If you could just try unmuting yourself. You don't have to use your camera if you're having problems with bandwidth. Or if you're having any problems unmuting, you can always also type an introduction into the chat. Hussein? Okay, I think maybe Hussein's having a bit of difficulty. Maybe I can move on to Hasvine Manganda.
Yes, I'm Shunei Manganda.
Yes, go ahead. Would you like to tell us a bit about where you're from and what it is that you currently do?
Okay, I'm from Malawi, but currently I'm in India. I'm studying at Sanskrit University, Masters in Biotechnology.
Great, thank you for joining us today. And then if I can ask, is it Irakoze to unmute and please introduce yourself if possible?
Thank you.
Okay, if Irakoze is having some troubles, maybe we could have Bulida Wilson. If you could unmute yourself and just give us a short introduction. Walida, I don't know if you're able to unmute. Otherwise, we can maybe get a short introduction from Claire Brockbank.
Hello, good afternoon, everyone. My name is Claire Brockbank. I'm a family physician. I'm from the UK and trained there, and I worked in the UK for 10 years before relocating to Botswana, where I've lived for 10 years. I'm a family physician in private practice, and I'm a lecturer at the university for the undergraduate students.
Great, thank you for being with us today. Next, can we have Deborah Gray? If you could unmute and introduce yourself, please.
Hi, good morning, everyone. My name's Dr. Deb Gray. I am a family nurse practitioner. I've been in practice for 32 years in primary care. I'm an autonomous practitioner. I'm also an adjunct scholar at the University of Botswana. I was in Botswana, Claire, for a year, teaching at the University of Botswana and working with the World Health Organization there a couple of years ago. So glad to hear someone else is in Botswana. I'm also I'm a professor of nursing at Old Dominion University in the United States. I'm the associate graduate program director for 12 advanced practice nursing programs, and I teach full-time there. And I also still have a part-time practice. I still see patients part-time. So I'm also on the advisory board for AfroPHC.
Great, thank you so much. So I think that is everyone for now. If we have more people joining, we can have some more introductions. For anyone who joined perhaps a little bit later, my name is Jamie Colletti. I'm a medical doctor from South Africa. I'm currently completing my community service medical year in the South African Military Health Services, and I am a member of the AfroPHC Executive Coordinating Team. And with the help of Cynthia, we will be facilitating this AfroPHC Southern Africa chapter consultation today, whereby we just like to get some input from the participants from today on several of our key questions. I've been sharing the draft policy framework link on the WhatsApp group. If you haven't yet joined our WhatsApp group, please feel free to do so. The link has been posted in the chat by Prof. Shabir. So basically our agenda for today's meeting, so we've done a bit of introductions, then we're going to go on to Mercy, who's going to give us a presentation on the introduction to AfroPHC. And then I myself would like to give an introduction to the draft policy framework with just a bit of summary on that actual document. And then we're going to move forward where Cynthia will facilitate our questions and discussions. And some of the questions that we're asking today are, what are the challenges of PHC within your region? We're also going to discuss the draft policy framework, what individuals liked, what they don't like, what they think needs to be added or maybe emphasized. And then we'd like to also discuss how do we take AfroPHC forward. So thank you all for being here. With that, I'm going to hand over to Mercy for our introduction to AfroPHC and the chapter consultations. So thank you so much, Mercy. Mercy, are you fine?
I forgot to unmute. I switched on my video. Forgot to unmute. Sorry.
No problem. We can see your
everyone.
screen.
Yes. So I'm going to go through a brief introduction of AfroPHC, where we started, how we've been doing, where we are, and where we need to go. So, Jamie has already gone through the agenda. So this is a bit of a background and timeline of where AfroPHC started. And the idea was first born during the Wonka Africa Conference of June 2019 in Kampala, Uganda, where there was a WHO Afro workshop, and with Prosper Tumisime, who works with the WHO Afro. And John suggested that it would be good if Africa had a forum to discuss and advocate for the agenda of primary healthcare, like the European one, the European Forum for Primary Healthcare. And after that, discussions went on in August 2019 at the AfroPHC conference in August 2019 in Nairobi, where with the Interprofessional Practice and Education Network, Prosper Tumisime continued with the discussion, bringing on board nurses, doctors, and other people as team members. The key people there were Bongisi Banda, and Champion Nyoni, who are nurses working with AfroPHC. And they decided, yes, let's do this. Let's form an professional team and form the Africa Forum for Primary Healthcare. Then in September 2019, there was a short proposal during the UHC declaration in September 2019 of formation of AfroPHC, with many organizations supporting this venture, including Wonka Africa, TAF, WHO, Afro, AMREF, and PharmaFarmed, amongst other organizations. So this is what the initial pitch looked like why do we need AfroPHC? And we as healthcare workers on the front line of primary care services in health systems of Africa and supporters of primary healthcare approach are committed to achieving universal health coverage in Africa. However, it is very easy for UHC to be seen as a financial solution without the required reform in primary care service delivery. The centrality of PHC to UHC efforts may become lip service, especially when frontline primary care workers' voices are ignored in Africa. So as AfroPHC, we plan to bring together the leadership of all healthcare workers at the coalface of African primary care, and to ensure that we all have a voice in policy on primary care and primary healthcare in Africa. We hope to develop an Africa Forum for Primary Healthcare as the voice of the primary care and primary healthcare team and its supporters, sharing and supporting each other in advocating for PHC. This statement would later on serve as a mission for AfroPHC. So there were initial workshops after that in 2020, where there was introductions of the people who came together to form AfroPHC, with a launch workshop happening in September 2020, where people just got to know the team and what the community expects from primary healthcare and how a primary healthcare team should function. And from there emerged AfroPHC statement with key principles as primary healthcare as people-centered, with primary healthcare human resources, capacity development, teamwork, inclusive primary healthcare leadership, and advocacy. And in December of that year, there was more reflection on the statement and workforce issues in primary healthcare in Africa and how to tackle them going forward. And the discussion went on during the APN symposium in November. Then now the official launch of AfroPHC and an official annual general meeting occurred on 20th of April, during which members who had joined AfroPHC by then elected a 9-person executive board from different parts of Africa and also different professions. Later on, 3 more members were co-opted to improve the functions of the board. Then from there, there was stakeholder engagement, where 31 AfroPHC supporting organizations signed on. An advisory board was set up, and there was also engagements with WHO Civil Society Commission on how WHO can better engage civil society in decision-making in global health. Later on, there was the formation of the Youth Hub in order to encourage the participation of youth also in the discourse of primary healthcare in Africa. So where are we now? Based on AfroPHC's values and also mission and vision, we have developed a number of activities that are being carried on to this day in order to serve that vision and mission. One of them is the policy workshops that we have the third Tuesday, of every month. So far, we have had in 2021, we had about 10 workshops. And this year already, we have had about 8 workshops, with one happening next week on different issues that affect, different topics that affect primary healthcare. And I'm glad to hear that, someone mentioned he's passionate about One Health. We had a workshop as well around One Health, and we're looking to take the conversation forward as well and pursue it as one of the important goals of primary healthcare in Africa. And out of these policy workshops came the building the primary healthcare team for UHC in Africa policy framework that we will discuss later today. And remember, having the voice of the frontline healthcare workers in Africa is an important part of AfroPHC. So this document is a reflection of those voices, their challenges, and what could solve those challenges. We also have training. One of the trainings is the leadership management and governance for health system strengthening course, which is in partnership with AMREF. We run it from 2021, and now we are with the 2022 cohort with 372 engaged with a monthly meeting and discussion group. So far, we are doing well. We are at module 7, and we have 3 more modules to complete and have cohort 2 graduate and cohort 3 enroll from January next year. We also have clinical CPD training with CPD points awarded every Thursday of every week from 1 to 2 p.m. GMT, where we usually have 500, 600 plus participants from all across Africa. We are also in the process of developing a curriculum framework for a 2-year online clinical postgraduate diploma in family medicine for different people in the primary healthcare team, including medical officers or general practitioners, clinical officers, and also nurses. And Prof. Shabir, our executive coordinator, is leading the process. In the research area, we also have the AfroPHC research mentorship program, which started earlier this year, and we had 298 people register their interest, with 19 researchers finally submitting a concept note for mentorship on the 31st of July. Amongst other things, we are also involved in the African Population Cohort Consortium grant, where we received a grant from the Wellcome Trust to develop an African Population Cohort Consortium. We are also in the process of developing other research relationships and programs to enhance primary healthcare research in Africa. In terms of communication, we have a website, afrophc.org. If you go there, you'll find information about all the activities I've talked about, and so much more in terms of what we have been doing, what we have done, and what we're looking to do as well. We have a Google group through which emails and communication goes through. Right now, I think we are at 1,600 or more members and counting. We also have social media engagement on Facebook, Twitter, YouTube, and now also Instagram and LinkedIn. We also have WhatsApp regional chapter groups to enhance a more of regional engagement with the various countries in Africa, and also contextualize various PHC issues depending on geographical location and also different challenges. In terms of administration, we have an executive coordination team led by the executive coordinator, Prof. Shabir, and the executive coordination team is a group of young healthcare professionals from across Africa who have volunteered to lead the various activities that I've just talked about and support the executive coordinator in his functions. We have a strategic and operational plan, which is available on our website. And our membership, as I've mentioned, is from 40 plus countries in Africa, and we are at 1,600 members plus and counting. This is the executive coordination team that I have mentioned, and you can see we have different people leading different portfolios. Young people who have volunteered and are under the mentorship, or have been under the mentorship of Prof. Shabir. Coming down to the main reason why we are here today is the PHCPI microgrant to develop our policy framework as AfroPHC. And the goal of this grant project is to deepen the draft on AfroPHC policy framework, building primary healthcare teams for universal healthcare coverage in Africa. And the main thing about this document is we want to focus on effectiveness. How effective, what does an effective primary healthcare team look like, and how can it be better supported in its functions? So I think Jamie mentioned that she'll share the policy framework on the draft policy framework on the chat. So if in case you've not gone through it, you can skim through it. It's also available for comments as we wrap up final write-up of the draft. Chapter consultations began as part of a way of deepening engagement at country level with AfroPHC and AfroPHC members. And that now developed into also a way of getting the voice and the opinion and the comments, and as well as input from different countries and regions for the AfroPHC policy framework. And we have members of the AfroPHC Executive Board leading as facilitators for those chapters. So you can go to learn about chapters of your region. If you're not from the South African chapter or region, you can go to our website and click on chapters, and you can learn more about how you can join the chapters, join the WhatsApp group, and see join the discussions within your chapter and region as well. Jamie already mentioned what the chapter consultations look like, discussing challenges of primary healthcare in the region, looking at the draft policy framework and reviewing it, and getting input and comments from you. And how do we take AfroPHC forward within the South Africa region? And finally, we want people to step up and say, I'm going to be part of the interim regional task team to help deepen discussion within the region, and also to help organize activities and collaboration within the region for primary healthcare. And with that, I say thank you, and I hand it over to you, Jamie.
Thank you so much, Mercy, for that concise and comprehensive overview of AfroPHC, as well as our chapter consultations for today. So the next item on our agenda is I'm just going to take us through a brief presentation on the AfroPHC's call to Africa and the draft policy framework. So let me just get to that on the screen. Okay. Right. Okay. So we're here today for our chapter consultation, and our call to Africa is AfroPHC. Join AfroPHC and build effective primary healthcare teams for universal health coverage in Africa. So just a bit of background, we would like to heed the call of African health professionals, recognize African challenges and opportunities, and note global primary healthcare milestones. And the key elements of this call are to train, recruit, and maintain a sufficient frontline PHC workforce, support primary healthcare with resources, and build robust primary healthcare systems. So we're going to focus on those three areas of the primary healthcare workforce, resources, and systems within our call. So starting off with the primary healthcare workforce, we would like to strengthen human resources for primary healthcare, for which we call on Africa to build a larger, better trained primary healthcare workforce with more opportunities, including educational, financial, and clinical opportunities, and greater resources to enable primary healthcare and universal health coverage. And we also want to build the team with task sharing and supportive supervision, for which we call on Africa to acknowledge the burden on all cadres in primary healthcare and embrace interdisciplinary teamwork with a mix of all health professionals, using respectful task sharing and supportive supervision for achieving primary healthcare and universal health coverage in Africa. Furthermore, we want to build distributed leadership, for which we call on Africa to embrace distributed leadership practices and education for it amongst all primary healthcare workers and managers to achieve primary healthcare and universal health coverage in Africa, as well as to build clinical governance. We call on Africa to embrace the important role of postgraduate trained family doctors in decentralized primary care settings to support clinical governance, coordinated care, and efficient referrals to achieve primary health care and universal health coverage in Africa. Furthermore, we would like to professionalize community health workers, for which we call on Africa to standardize, professionalize, and decently remunerate community healthcare workers that are strongly integrated with the primary healthcare team. And furthermore, to aspire to a target of 1 community health worker per 1,000 persons by the year 2040 in order to achieve primary healthcare and universal health coverage in Africa. And we want better management of human resources, for which we call on Africa to clarify and harmonize primary healthcare workforce nomenclature, for the different categories and disciplines in primary healthcare, and to then embark on labour market analyses in primary healthcare, both public and private, and specific primary healthcare human resources for health policies and strategic plans to scale up the primary healthcare workforce by the year 2025 to achieve primary healthcare and universal health coverage in Africa. And lastly, under the primary healthcare workforce, we want there to be better development of human resources, for which we call on Africa to implement a robust educational and credentialing infrastructure for developing a competent workforce that is dedicated to delivering comprehensive primary healthcare services necessary to achieve universal health coverage in Africa. Now on to primary healthcare resources. We want to view political and funding action for primary healthcare as an investment, for which we call on Africa to regard health as an investment and to leverage political goodwill for action on primary healthcare and universal health coverage by defining primary healthcare in budget terms, ring-fencing the financing of primary healthcare, and committing to at least 2% of their GDP on primary healthcare for universal health coverage in Africa. Furthermore, we want there to be a fight for global solidarity action on primary healthcare funding pools, for which we call on the world to re-examine global social solidarity on primary healthcare and strengthen contributions to primary healthcare for universal health coverage in Africa as a priority, starting with high-income countries increasing donor aid to 2% of their health spend and donor aid funds allocating 30% to an African Union funding pool for integrated primary healthcare and universal health coverage in Africa by the year 2030. We then want management of pooled funds with strategic purchasing, for which we call on Africa to work towards better funded single pools for universal health coverage funding, prioritizing strategic purchasing for primary healthcare with standard and transparent contracting of both public and private providers in empowered, decentralized units of primary healthcare for universal health coverage in Africa, as well as reform primary healthcare payment with blended capitation, for which we call on Africa to embrace simple national contracting of primary healthcare teams with mixed or blended capitation models, including capitation, fee-for-service, and performance payments to achieve holistic and responsive primary healthcare and universal health coverage in Africa. Then onto primary healthcare systems, we want there to be embracing of the biopsychosocial spiritual approach for primary healthcare, for which we call on Africa to embrace the discipline of family medicine with its biopsychosocial spiritual approach to care to achieving primary healthcare and universal health coverage in Africa that is personalized, comprehensive, continuous, and coordinated in line with global standards, as well as envision comprehensive person, family, and people-centered primary healthcare, for which we call on Africa to embrace primary care, defined by the World Health Organization as an essential level of care that needs to be responsive, person, family, and people-centered, and covers the full spectrum of care within the paradigm of One Health for primary healthcare and universal health coverage in Africa. Furthermore, we want health in all policies for robust primary healthcare, for which we call on Africa to prioritize primary healthcare as the foundation for universal health coverage, making health in all policies an integrating and developmental public health approach to decentralized government, strengthening the role of primary healthcare facilities with flexible models of non-hierarchical interdisciplinary teams, and creating integrated care models of public health service delivery of primary healthcare and universal health coverage in Africa, as well as to build quality in primary healthcare, for which we call on Africa to embrace the culture of quality and patient safety with strong teamwork, and to measure and monitor performance to achieve quality primary healthcare and universal health coverage in Africa. Furthermore, we want there to be building of the district health system, for which we call on Africa to place their trust in their frontline primary healthcare workers with decentralization of resources and the locus of control to bottom-up units of care, together with robust management functions to deliver an agreed upon results and operational accountability to implement primary healthcare and universal health coverage in Africa, as well as impanel defined populations to a defined team, for which we call on Africa to embrace the strategy of empanelment of a defined population and linking them to a defined, fully staffed and equipped primary healthcare team as a foundational step to achieving primary healthcare and universal health coverage in Africa. And then still under primary healthcare systems, we want there to be development of community-orientated primary care for Africa, for which we call on Africa to embrace community-orientated primary care in community practices of 30,000 by the year 2025, and aspire to community practices of 10,000 for achieving primary healthcare and universal health coverage in Africa by the year 2040. And then the blueprint for rural and marginalized health, we call on Africa to embrace the blueprint for rural health and rural-proof all health policies to support rural and marginalized primary healthcare comprehensively, especially creating step ladder entry requirements for educational institutions and rural or marginalized student immersion for the full primary healthcare team to achieve primary healthcare and universal health coverage in Africa. And lastly, under primary healthcare systems, we want innovative e-health that is patient and user-friendly, for which we call on Africa to embrace the variety of e-health solutions for primary healthcare by ensuring that sustainable national e-health strategies are supported by accessible infrastructure, interoperability, and user-friendly designs that enable the primary healthcare team and patients and populations to enhance quality and support new models of care in primary healthcare and universal health coverage in Africa. So in summary, our call to Africa is that we call on Africa to empower and build an effective primary healthcare team to achieve primary healthcare and universal health coverage in Africa. And we, as the African Forum for Primary Healthcare, commit to educating and empowering our members to support this goal in any way that we can. So that is just a brief presentation on the policy draft framework. I don't know if we have any comments or questions so far from anyone. You can feel free to post it in the chat or unmute and pose your question or raise your hand. Okay, so if we don't have any questions at the moment, then I'd like to hand over to Cynthia, who will be assisting me with the questions for the rest of the meeting. So we look forward to hearing the responses from the audience. So Cynthia, when you're ready.
Okay, thank you, Jamie. Thank you, Messi, for the two presentations. I'm sure the people who are around you, you have an idea now about what the policy framework is all about. And I advise that we continue to read the policy because it's on the website and Jamie has posted it. You can read, analyze it. If you are not able to put any comments today because you do not fully understand it, there's still room to send your comments through the website. But for the moment, I know we have people from across the region and beyond the region. They are all welcome to help us to improve the policy that you are working on. We would like to know from all of us, what are the challenges of primary healthcare in the region? I'm sure in our different regions, in our region, and in our different countries, institutions, we do really have some challenges that we would like to share today so that those framework that we are working on. It's open on the chat, we'll discuss that.
Cynthia, I just want to say your sound is a bit challenged. I don't know if maybe it will be improved if we switch off the video. I could hear what you were asking, but maybe just it might be improved if if the video without the video, because I can hear you, the sound is a bit challenged on your side.
All right. Let me switch off the video. Can you hear me now?
That's much better. Thanks, Cynthia.
It's much better. Okay. Now, I was inviting people to share challenges of primary healthcare in the region. And I was saying that we have heard the introduction about the policy, about AfroPHC, and we also got a summary of the proposed primary health, the AfroPHC policy. So we are still inviting comments from all of us here, and we would like to share challenges that we are experiencing in the different countries in the region. I'm aware that there are people within Southern Africa region and beyond. We are all welcome to put in our ideas and share the challenges that we're facing. Thank you. Open for discussion. I'm trying to see.
Hello.
Yes.
Hello.
Yeah, welcome. Yes.
I'm Raila Koru, a public health officer by profession and a menstrual hygiene champion Kenya chapter. I'm also undertaking an edX course on menstruation in global health practices and policies. And one of the challenges on the issue of policies, especially in African setup, we always produce beautiful and handsome policies, but implementation becomes an issue. I'm saying this because around 2019, Kenya launched the menstrual hygiene policy document. There was a document and a strategy, but since then it has remained on paper and people have not taken up menstruation as an issue. Yet the World Health Organization in 2018 recognized menstruation as a health condition, and it gave a definition. So menstrual health and hygiene is a recognized condition as per WHO as from 2019. But where we have not, the implementers and the policymakers have not accepted it because no sensitization has been put in place, no advocacy. So for us who are in that sector, sometimes when you meet people and try to introduce it, you are always being seen as if you are introducing something which is a taboo. Thank you.
Thank you very much for your comment and for your contribution. And I think this is why most likely we are going chapter from chapter to chapter, and we are trying to consult as many people as possible so that we speak with one voice in terms of implementation of the policy development. And very much for that contribution. We are open for other discussions, and it's been taken note of.
Okay, hello, Dr. Chongo from Zambia here. I think one of the greatest challenges that we've been facing, especially I think in Zambia as young people in the health sector who look up to our mentors, who are consultants, who are faculty at universities, who used to supervise us on the wards when we're still students, there's just this very negative attitude towards anything primary healthcare centered. I don't know if it stems from a lack of understanding of what primary healthcare really is, but as a country, generally we've been gravitating more towards specializing. That's for doctors, even nurses. There's been a very big move towards specialization. Is it critical care nursing? Is it neonatal nursing? Is it, and so primary healthcare, I think, comes as an affront to the direction that Zambia has been taking. And so even when you'd find maybe like a junior intern doctor or maybe a student, when asked, oh, what do you want to do? Every time someone says something like, oh, I want to be a family medicine practitioner, or I want to go into primary healthcare, usually they'd be very negative rhetoric. People would be like, oh, why would you waste your time doing something so nondescript? Why would you do that? And I find that it might seem like a small thing, but most young healthcare workers or people who are still students are very pliable to like the general note. So we'll always struggle to get proper training and recruitment of people for primary healthcare if even in institutions, hospitals and universities, if the faculty don't respect what primary healthcare is, if they don't respect what family medicine is, we'll find very few people going into the field.
Thank you very much for your contribution. Is there anyone who would like to respond to what he is saying or to add to what he is saying? It's a valid point.
Cynthia, I don't know if I can perhaps add something as well.
Yes.
Yes, thank you for that contribution. I think it is very relevant and something that I've definitely seen myself having recently completed internship in South Africa. I feel like the biggest question amongst my colleagues who were in my year is, what is the next step? What are you going to specialize in? And it's almost like that's the goal, is to do something further. And there's not enough emphasis put on PHC. So I think that what you've said about Zambia is definitely something that I've also noticed in South Africa. And I also think something that's come out in a few of our other chapter discussions, and something that Mercy's actually mentioned a few times, is that a lot of the time when you mention primary healthcare or you're a primary healthcare physician, people don't always know what exactly that means.
Thank you very much for those contributions. I don't know. Yes, there's a hand up. Yes, Onalena, go ahead.
Hello, everyone. I liked the comment, the previous comment before the one that we just alluded to. She talked about the fact that in Africa we are used to the culture of developing very beautiful policies, and I share the same sentiment with her. And my comment here is that one of the contributing factors to that is that most of the time when we develop policies, and monitoring and evaluation always come the afterthought of all these policies that we're actually developing. And you will learn that we actually have this document and we don't even know how are we going to track all the processes? How are we going to ensure that we actually implement all these policies or all the strategies that we have actually developed in these policies that we have developed? So it's very critical that every time when we develop these policies, we actually also ensure there is an evaluation plan in place, or implementation plan plus evaluation plan in place, to ensure that we are implementing our activities accordingly and timely, and even to an extent that we even allocate responsibilities and even set timelines for each and every activity to ensure that everything is done as planned. And that is the very, very important area that can help us to actually have these documents that we are developing being implemented accordingly. Thank you.
Thank you very much. I think that is a valid point that is emphasizing what has already been said, and we value such contributions. I see there's a hand. Claire, please go ahead. Claire, please go ahead.
Thank you. Yes, I have a comment about the role of family medicines and their value attached to them. So I finished my family medicine training 20 years ago now in the UK, and was met with very similar comments to what we're hearing now. Part of the change in the view of family doctors was really by enabling more general practitioners to have a formal postgraduate training program. So that happened in the UK about 25, 30 years ago, that everybody wanting to go into primary healthcare had to do postgraduate training. And in the UK, that's still labeled as a GP. You cannot be a GP without doing your postgraduate training. And now in the African region, we're starting to see more of us developing postgraduate family medicine schemes. But I fully support your view that it's often seen as a not an important role, as a second-rate option. The value isn't there. There is a huge role placed on specialist care, which is not really what the region needs. We need higher skilled primary care team and lower numbers of specialists. So we need to have a bigger base of us at the ground. So part of that, I think, comes with time. So as your family medicine departments develop and the number of family physicians grow, that starts to be seen as a real career path. Here in Botswana, we have quite a good postgraduate family medicine cohort, which started their training both here in Botswana and in South Africa, but now all of that has moved in country. The challenge is that once you've done your MMed in family medicine, you don't have a job allocated to you in the government system that recognises your role. So you either go back to being a medical officer, so your pay and the status and your responsibility is the same, or you get moved to an administrative role in the DMHT. So you become a head of a DMHT or a superintendent of one of the regional clinics or hospitals. So you lose your patient-facing role. So therefore you lose that enhanced clinical skill. So I think some of that challenge is how does the university and the postgraduate training programs link with Ministry of Health to ensure that there are jobs available for the graduates that you are then training. And the third point I have is that anyone can go and be a GP. So you can go into primary care either as a medical officer in the clinics around the country or in private practice, almost straight from your internship. So of course that doesn't help develop skills and the level of training that you want to provide a really good primary healthcare team. And we're having some challenge to try and see how do you get the current GPs, especially those newly trained ones, to be able to, or sort of be enforced to go into doing a postgraduate training. So things like that shorter 2-year diploma, so that everybody has done some postgraduate training before falling into primary healthcare. So those are my 2 comments. So 1, I think it will get better, and 2, you have to link up the university training with the Ministry of Health plan. Otherwise, skilled trained family doctors do not get allocated those roles. Thank you.
Thank you very much, Deborah. Your hand is up. Go ahead. Deborah, please go ahead.
Thank you. I'm sorry, Cynthia, you broke up. I couldn't hear. I just want to, can you hear me okay? I just want to echo also what Claire also said. There's a similar issue in Botswana for nurses who've done their bachelor's and go for their master's as family nurse practitioners, and also the ones that are doing the BSN as well. They're also not able to, their skills are not recognized, and so they're put back on the floors, and they're not given the positions that they are trained for, and it's a big problem. So again, I agree, not only for family medicine, but also for nursing. It's important to partner with the ministries of health and also the boards of medicine and boards of nursing to ensure that once you do educate anybody who is working in primary care, that they're given the positions that are consistent with their training and their abilities, and that's crucial. So, and we've seen that across the board, not just in Botswana, but other countries as well.
Thank you, Deborah. Anyone who would like to react to the comments that have, oh, there is Anna. Anna, please go ahead.
Are you talking to me, Anna Dania? Can you hear me?
Yes, we can hear you.
Yes, we can hear you, Anna.
Yeah, I wanted just to add on a comment that I would see as a person who has been very much thinking about research engagement of practitioners, that you should look not only on the connection, not only on the connection of with the Ministry of Health, but also consider the development of strong professional organizations in each country who would go hand in hand with university departments of nursing and family medicine. And I would see also that the university departments, together with the professionals in the field, to be those who will engage again hand in hand to promote research, which is also an advanced step for the primary healthcare professionals. And unfortunately, in the UK, it is separated in the higher degrees education now. So far that I know from the connections I have in the UK, that this is some problem. And I would like you not to follow that path in Africa. We have to learn from the international experience. And I would see that the education in Africa, the higher degrees, should promote research anyway to be implemented in the practice later. In any forms, I mean, as contributors, as co-investigators, as like data collectors, like people who can read the data they are producing in their practices and so forth. Thank you.
Thank you. Thank you very much. Lena, please go ahead.
Yes, I wanted to talk to the fact that one thing that I've learned since I've been working in the health system, there are certain cadres which seem to be dominating the health system as compared to the other. I think if we can get rid of that culture of actually recognizing that we complement each other as the different cadres, and even our progression and recognition in the health system will make everything, will make everyone feel valued and important in the health system as much as the service delivery is concerned. Thank you.
Thank you very much for your contributions. Are there any reactions to what has been put forward by a number of people? As far as I'm concerned, these issues have been really raised in all the regions where we've held the chapters, and I would really say we seem to be facing more or less the same challenges, which we should address as we go through this policy framework and the implementation. I think one of the key issues that was brought in was we developed beautiful policies, but implementation is never there. And the issue of monitoring and evaluation, and there was quite a strong point about the primary healthcare being underplayed as compared to other disciplines or specialities. And this really takes us to be discussing then how do we want to take AfroPHC forward? It's us who have to take it forward. So let's discuss. Deborah, I see your hand. I hope I haven't ignored you. Deborah.
I don't know.
Hello, Deborah, can you hear? Okay.
That's a mistake.
It's an old.
It's an
is
old
it an
one.
old hand? Okay.
No, that's fine. That's fine. But I think we should earlier on Jamie did indicate that what is it that we like about this policy framework, what is it that we don't like, and what are the suggestions, and how should we be taking AfroPHC forward? Because we need to move it. We've identified the challenges, we should address those challenges, and we should move forward and make sure that it's fully implemented and it enjoys equal recognition as other areas of speciality. I did not hear anything from Zimbabwe. Anyone from Zimbabwe except me? Yes, there's Tabiso Ngwenya, I think. Are you still there? Anyway, I don't seem to see
There's some hands up.
But,
Cynthia,
okay.
there's some hands up.
Thank
Yeah.
you. Yes. Yes, Onalema and then Pulida afterwards. Go ahead, please.
Yes, primary health care. I think we should be very deliberate about what we really want to achieve with primary health care. I believe that primary health care should form the basis of our health provision. For example, like truly speaking, when we look at communicable NCDs, NCDs nowadays, you will find that most of the time they are an attribute of how we are handled when we are actually providing medical care. For example, you find that people are actually treated you find most of the time we misdiagnose people because we are not applying a primary health approach, whereby we understand the social aspect of health that may be contributing to the health of individuals as they come to our facilities. So personally, I think it's all about being deliberate and actually coming up with a model whereby we ensure that prior to treating people, we actually understand the social aspects of their health. Thank you.
Thank you very much, Onalena. Pulida. Pulida, go ahead, please. Hello, Pulida, please go ahead. Pulida Wilson. Can people hear me?
Pulida, can you hear us? Your hand is up. I don't know if you want to make a comment. If you're struggling to unmute, you can also post in the chat.
Hello.
Yes, go ahead.
I'm Frida Wilson from Uganda. Comprehensive nurse. Sorry, I came in late. What I want to put across is that here in Uganda, the problem is we just end studying at school, but implementation in the community, that is the problem. The force, and there is the government doesn't even pay or doesn't allocate the budget to implement primary health care. So people, all students, they just learn at school and they just stop there. That's my comment about it. So the way forward is to find it. The way forward is to find a way how can we reach in the public, most especially in the villages. And the other issue is how to collect the funds so that we get enough manpower to reach in villages. That is it. Thank you.
Thank you very much for your contributions. Any
Cynthia,
other comment? Yes.
I just see here in the chat we've had some comments. So Rail Akuru has mentioned that professional and cadre wars and conflicts is widespread in Africa. I think that was in relation to what are some of the issues with PHC within the region. And that is something that we have mentioned in previous meetings. Civil unrest and conflicts within the countries is definitely something that would impact health. And then we've had Bulida, I don't know if that's a new hand.
No, I've shared. I've shared.
Oh, you've shared? Okay, great. And then Onalena.
Yes, I just wanted to share experiences with primary healthcare in terms of Botswana as a country. I think in Botswana, before 2011, we used to be practicing primary healthcare. We used to be having primary healthcare services. And when we changed leadership, due to political leadership change, we had to move now. We started centralizing health services, and now we moved away from the primary health way of doing things. And since COVID-19, our country has learned the importance. They have learned that really primary healthcare is the way to go. And currently we want to go back to the primary healthcare that we used to have, because we acknowledge the successes that we had with HIV/AIDS, with the management of HIV/AIDS, the way our country was hard hit with HIV/AIDS. But we can all say we managed to succeed due to the fact that we applied a primary healthcare approach. So I think being able to allocate resources, like others have already said, and commit ourselves to primary healthcare can make a lot of difference. As for our case, where we learned, where we saw it, even during COVID-19, where we had to find ways of actually reaching out to the people in the community, because we didn't have those existing structures. But we were lucky because we had IDSR committees within our different districts, and that has really helped us in terms of surveillance and reaching out to the community. So all these things, I think that they need just a deliberate resource allocation and implementation. Thank you.
Thank you very much, Onalema. There was another comment again from Claire. It says, I may have missed this point in earlier meetings. Where and to whom is the policy document being shared, and who are we wanting to be held accountable for ensuring the points raised are acted upon? Mercy, are you able to respond to this question, or Jamie?
Yes, Cynthia, that's a good question. So where we are right now in the development of the policy framework, one, we want to get the buy-in of all the AfroPHC members in Africa, because this is a document that's supposed to serve as a blueprint for Africa by Africa, such that the primary healthcare team is contextualized according to our structures, politically, geographically, socially, etc. Then supporting organizations are also going to help us in terms of ensuring that we disseminate the document to as many people as possible. We're also doing stakeholder engagement with WHO, Afro, the different ministries of health at different regional and also country level, so that we can bring them on board. They can know this document is available and the principles within the document. And in terms of how are we going to hold people accountable over that? That is a structure that we are still building as we build more country and regional engagement, because it is important to hold somebody accountable. As for now, accountability lies with AfroPHC to develop the document, ensure it is disseminated, and ensure that all the stakeholders who are important around the table, the CSOs and the different ministries of health at different levels at country and regional level, are also involved in not only the development, but also the dissemination. And hopefully they will sign on to ensure that the document is implemented in their different contexts. So that's where we are, Claire. Thank you.
Thank you very much, Mercy. Any other contributions? We're still open to hear how we can take AfroPHC forward. We've seen the challenges, we've mentioned them, but we still need ideas on how we should take it forward so that we don't fall back again. Yes, there's a hand up. Ngabo, go ahead. Ngabo,
Thank you very much.
Go ahead and meet. Yes, thank you.
Right. Thank you. So I had a question. I feel like I might need some clarity. So when you're looking at the policy document under task sharing, like initially, like when you're looking at the initial part of like the paragraph that describes building the team with task sharing and supportive supervision, you get this, I don't know, I feel like it contradicts itself somewhat. Towards the end, for example, it says, for the protection of patients and ensuring quality care outcomes, task sharing should be subject to appropriate training in the new skills and backed supportive supervision, mentoring, etc., etc. Anyhow, I don't know. This particular paragraph, it didn't sit very well with me. How do you draw the line between, oh, let's task share to make everything more effective, at the same time saying, oh, if you don't have the qualifications for this, you can't do this particular thing. How exactly does one practically go around this? It seems a little, yeah, I don't know if I'm coming across clear.
Yeah, Mungabo, you're coming up. Sorry, Cynthia.
Go ahead, Mercy. I see Prof. Zend is up.
Go ahead, Prof. Shabir.
It's okay. Go ahead, Mercy. I'll come in after that.
I just wanted to respond to Mungabo's comment, because one thing that we have realized in this process is the concept of teamwork in the African context is not yet ingrained. The way we are trained to do solo acts. The doctor is trained to do what they're doing, the nurse is trained to do what they're doing, and then there are these very strict lines with which you cannot cross. But there are certain tasks that can be shared within a team. We're not saying that if someone is not qualified to do something, they should do it. For example, saying that a nurse should now go and perform cesarean sections, but they're not trained for that. That is not what we're talking about. That would be more of task shifting. Task sharing means this. We are working together as a team. There's a doctor, there's a nurse, there's probably a social worker there, and we share the responsibilities within the team. For example, who can take records, who can take patient records, who can maybe register the patient, who can administer, for example, vaccination. There are certain things that we can share within a team. For example, who can see maybe a chronic care patient? Do I really need to see a cardiologist every single day for my hypertension? Or can someone else within the team, still within their qualifications, see that very patient? Because if I'm just coming for medication and a routine check, I don't need to go to the cardiologist every day. I can even see the nurse that is nearest to where I am, or if the nurse is there today and the doctor is out, that nurse can still do the routine patient. Oh, this is my medication. This is the medication that I need, and this is what needs to be done. So it's a matter of, and the way it's been explained in the document, it's a matter of doing it with proper mentorship and supervision within the various within the various structures that we have set to ensure that a patient is not hurt or harmed and quality of care is maintained. So this is not task shifting, it is task sharing. It is working within a team and taking care of a certain block of patients or a certain community of patients. It's not task shifting. Thank you.
Prof. Shapir, then
Yes, thank
we'll
you.
have Red.
Yes, thank you. I think Mercy has kind of answered it. I think the truth is that current practice of task shifting is in the African setting is actually substitutions. In other words, oh, let's train someone and they can substitute for the higher level care. So let's train the community health worker because there's no nurse. And so we train them to function in a way, sometimes algorithmically, in a way where we can say, go out there and, you'll do it based on this, what I might say, algorithmic approach where there's done one-off training. Then they sometimes say, hang on, you know what, there's decline in that training. Let's call them back. Let's have more training. And this works under very strongly supervised conditions where that program has got funding for research, etc., and it happens. But in national systems, what is invariably happening is that people are going out there, task shifting with declining capacities, with no support supervision, and the quality of care that people are actually getting good drops in time, and it becomes a problem. What we need is a way in which you have a team around a population and a team acknowledging the fact that we don't have all the health professionals for everybody, but being structured in a way which is often well structured by professions to say, let's have a clinical associate or a clinical officer who can do certain tasks that a doctor could do and do it to a certain extent, but not do it in absence of a doctor, but do it together with the doctor, expanding the range and opportunity of the doctor, same with the nurse, etc. So it's very strongly premised, like Mercy has said, on teamwork around a population. And we want that kind of premise of teamwork around populations as opposed to this very factory-like approach to patient in primary care. And this is a cardinal change in thinking. It brings me to the point that Claire's raising as how do we hold people accountable for the issues in the document? I think we must not expect somehow we will plonk it in front of people and beat their heads beat the thing on their heads and that they will suddenly listen to us. It's an advocacy document, which means that we've got to use it to build momentum around a position. Whether it in fact even gets to the point of being accepted is another question. But in itself, as a document that speaks something far-thinking, it can have very powerful effects. And the effect is not just external to outside stakeholders. It is in fact very much internal as well, where we as primary health care practitioners are actually not entirely clear about some of these systems, about these issues. So the document is going to serve for us to all come off and to be on the same page about how the system should evolve. And remember that we're going through a consultation process. AfroPHC has got 1,500 people. We might reach another 1,500 people, but we need to reach as many potential people out there, not only primary health care providers, but people on the ground in the communities, and share to them, this is how we as primary health care providers think this could work. We've had organizations like the Primary Health Care Performance Initiative that have been involved in this process and the discussion, and they've seen us as being a very credible group with a very credible ideas, which speaks volumes. And I think that itself is something that, to me, that we got this $40,000 award speaks volumes for the credibility of what we put on the table. And there are many organizations out there that are really finding this document speaking very compellingly to them because it's really strongly integrated. And a lot of this has come out of discussions that have been held, through the policy workshops. So it's very grounded, and I think it comes from healthcare workers. Some people sort of are quite surprised by it, and thinking sometimes it's a little ambitious. But the truth is very doable. A lot of the problems are people at management level tend to come with their own thinking. And we've often said that really this is some of the challenge we have, is that primary health care is not being designed by people who work on the front line. They often are managers, they often push, sectoral issues, and they don't think in a comprehensive way. So let's come together as people on the ground. How would you like the system to work? And in fact, in the revision of the document, it's going to make that point much more explicit. That's where we function. That's who we are. This is how we see the future. And these are the issues that we need to unpack. We couldn't possibly also account for every single element. I saw somebody saying, have we got menstrual, hygiene in it? We realize that we cannot have every concept included in it, but we need to talk to some high level issues. And women's health is one of them that we need to account for. But I think people must realize that, we need to balance this. The document needs to be shorter rather than longer, but speak compellingly to all our, our instincts as primary health care providers on the ground. Thanks, Chair.
Cynthia, we can't hear you.
I'll give Rael unmute and speak.
Thank you. In Kenya, since we implemented the community health strategy.
I'm saying
sorry.
I'm giving the opportunity to Rael Akoro to speak.
Yes, thank you. In Kenya, we have been implementing community
We
health
could hear
strategy.
you. Go ahead, unmute yourself.
Oh, yes. Do you hear me now? Hello?
I think we all can hear you, Rael, so don't worry. I
Thank
think Cynthia's got a challenge on her
We
side. It's
can
okay.
hear you.
Thank you. In Kenya, we implemented
you are audible.
Community health strategy since 2013, 2014. And when the national government brought up their policy, when we were going through the policy, we discovered that the policy was not good in communities where illiteracy level is very high. So we gave those issues, and they allowed that we hire community health volunteers with low education, as long as they understand the language. Now, due to that, the health services in Turkana County on all those pastoral areas where they still practice nomadic movement, migratory, they have improved because we have engaged community volunteers from within the community. They don't know how to read and write, but we have done a document in the Turkana language where we had to translate it from Kiswahili to Turkana language in a very simple manner. So even the curriculum, we have a curriculum which we always administer using the Turkana language, as long as we are using the adage which says, if you want people to understand something, use the language they understand, not the language they know. So in this particular case, in the pastoral communities, people understand their own language. They just know Swahili, but they don't understand. So what we have done is particularly in Turkana County is to translate those pamphlets, those information in the Turkana language. And it has really done wonders because communities, when the child reads, maybe the child is in standard 7, standard 8, he knows how to read. So when the child reads it in the Turkana language, there is no any other explanation because it's the language which people understand. So if we can pilot such issues, especially in areas where illiteracy is still at around 70%, it will be good for us to pass that information. in the language that people understand, not the language people know like Swahili or English in Kenya. Thank you.
Thank you very much for your contribution. There was another hand up. Please check the chat. Okay, it's just a reminder that please feel free to put your remarks on the chat if you are not able to speak. We are still inviting comments if there are any on any of the issues that we've discussed. Please feel free, because your presence, your contributions will strengthen the document that we are working on, and together I think we can make it a valuable document, something that is going to be respected by everybody, and it's in that manner it's implementable. Any comments from anyone else? Mercy, Jamie, and anyone else in this meeting, you're welcome.
Yes, I think mine would just to encourage people to read through the document and add your comments as well, and encourage as many of your colleagues as possible. Just share the link so that they can also interact with the document, because like Prof. Shabir mentioned, we need as many people as possible interacting with it and also giving their input, so that what we have at the end of the day is the voice of the primary healthcare workers and other healthcare workers in Africa who are the frontline, because their experience is important in implementing different policies, what worked and what did not work. So I think that would be important. And also to just, even at chapter level, to continue the discussion, especially in areas of challenges. I think I've had so many good ideas today in terms of what has been done, what is working. I think I really appreciated what Claire mentioned in terms of, for them, they realized that they had to align the training of primary healthcare workers, nurses, and also physicians, the GPs, with the Ministry of Health strategy, because what we find is we are training primary healthcare workers, we're training family nurse practitioners, we're training family physicians, but the government do not know what to do with them, because in their policy, in their budgets, in their planning, they do not include primary healthcare. So it's up to us to advocate for that, because there's no need to keep churning out family physicians and then they do not find a place within the healthcare system, and then they end up in hospitals serving as physicians, serving as emergency care doctors, serving in anywhere other than at the primary healthcare level. So I think that is something important that I have learned, which I had not had before in our other consultations and discussions, which I think is very important. So thank you everyone for this very enriching discussion. So please go to the document, just read it slowly and keep putting your comments there. Thank you.
Oh, thank you very much, Mercy. May I hand over to Jamie? As the chair, please take over, Jamie.
Great. Thank you so much, Cynthia, for going through those questions. We have an additional comment from Deborah in the chat that says, thank you, everyone. As International Council of Nurses rep on this, I will take this feedback and the draft document to ICN leadership for additional comments. So thank you so much for that, Deborah. I was just wondering if anyone else had any more questions that they might have, maybe not necessarily additions on challenges within PHC or the draft policy framework, but any questions that they might have had coming across the document. Okay, so I don't think we have any additions. Any other comments on what maybe other members have stated already? Yes, Onalena, feel free to unmute and share.
I have a question. I see here the 3 shifts that you want to make different, and my comment here will be it's very critical that when we are thinking about all these shifts, we think about the measures and the definitions that we're actually going to apply across the different areas or thematic areas that we want to achieve. For example, when we say quality health services in the community that work around their needs, preferences, and everyday lives, one may ask, what is quality? When we say quality health services, what do you actually imply in this case? I think it's very critical that we have a standard measure or standard meaning or definition to all these variables, so that at the end of the day, when we measure ourselves, we have a standard understanding. Thank you.
Thank you, Annalena. I don't know if Prof. Shabir, you'd like to comment on that and share?
Yes, thank you. I think, Annalena, that's in fact a key element, a paragraph that we're going to have to add into the document that speaks to the sort of PHC PI performance framework, as well as the kind of indicators that they've been pointing out, the vital signs framework. So we're going to have to incorporate the question of effectiveness. How do we tell if primary health care is effective? And I think it's about exactly what you say. What is the performance outcomes that we're looking to be able to measure, improvements on? So thank you. That's a very important point.
Thank you so much, Prof. Shabir. I don't know if anyone has any addition to that comment or any other comment they'd like to make.
Hello, hi, it's Claire Brockbank. I had
Yes.
one comment about the universal health record, or the e-health record. It may be a bit outside the scope of this document, but is there any opportunity with trying to link with already existing and working systems? Certainly in Botswana, we have quite a large number of different electronic health records that are not complete, and they don't really talk very well to each other. And there's no interaction between what's in the government sector and the private sector. So it's definitely a very ununified set of computer things that we have. Ministry of Health is trying to look at some options, but it's really to think about how can we try to build in other countries that have already developed robust systems that might translate well into our setting, so that we're not reinventing the wheel for systems that have been in existence for, for example, the NHS in the UK. There's sort of 20 years of very good primary healthcare computer systems. It's probably outside the scope of this document, but it might be so that we use technology that's already there. We don't have to try and think again to start things up. I don't know if that really matches what we're doing. It's just a thought of how do we try and bring in what's already in existence.
No, thank you for that comment, Claire. I see Prof. Shabir has his hand up. I don't know if he'd like to speak to that.
Yeah, just to say thanks, Claire. I think it's an important question you raise about how our governments are pursuing the embrace of electronic health records. And we think that, in Africa, people might say, does Africa need electronic health records? It's we too far away from that kind of thing. It's not, we're not ready for it. But I think that's the kind of far thinking we need to embrace. And we need to say, listen, Africa has the ability to leapfrog a lot of the legacy problems that occur in other parts of the world, use what's best practice, and find ways in which EHRs can come to play in our system and, in fact, be delivered cheaply and really effectively in terms of outcomes. But the premise of which that occurs is not to make the mistakes that other governments have made. And the current best practice globally is a question, a concept called interoperability. So in fact, it is about saying, whatever the systems they are, they must all speak to one kind of, they must all speak to each other. So interoperability comes by way of national governments having that as their policy that embraces interoperable systems, and it requires government to become the sort of custodian of that process. And in a way, then allow all sorts of other systems to come in. But being the custodian, it sets certain standards, requirements that anything in the system needs to actually collect information that is talk to each other and a minimum set of information, etc. And that's what we want. And then there's a whole lot of possibility that might emerge after that, because the technology space is so innovative. And if we create the right systems of payment and incentives for people to perform, then you'll find they'll want to take on all this new technology to actually get them to address it. But government needs to lead them down that road. And that's what we put in it. And we say two other things. One, it must be patient friendly. And it must bring the patient into it, because many EHR systems do not speak to that. It's a relatively new concept about patient portals or patient access to data, and it's something we want to encourage. And the second thing, of course, is the simple thing. It must be provider friendly, because the person who's sitting across the table, sitting with a computer in front of them, does not want something that detracts from the care that he's affording or she's affording to the patient. It must be easy to use, and not just to input data, but to get out data. So these are very basic principles, but they actually are very far-thinking, far-sighted principles. They came out of our workshop, that a lot of these ideas came forward that, this is where we need to go through. There was even talk about, in the document, in the workshop, about crypto or blockchain. And, it's part of the conversation. It's about technological innovation. It extends it extends the idea, but the principles remain the same, which is make sure it's interoperable, make sure it's user-friendly, and patient and provider, and in fact allows the provider, because that really drives better information, allows the provider and the patient to be able to extract the data, use the data, and then you'll find that the quality of data improves a whole lot. So I think it is within the scope at a principle level for the document, but the document couldn't possibly tell you everything about everything and anything about EHRs or even IT or digital health. So I think, thank you for the comment. I hope that, you feel more assured with the response.
Thank you so much, Prof, for that response. We just have another hand up from Onalena. Onalena, you can unmute and share.
Yes, thank you. I like the issue of integrating our data. I think it's a very critical point. But one thing that I've learned, it's our problem, especially here in Botswana, as she has alluded to, is that we have standalone data collection systems that are not integrated. But at the same time, even though they're just standalone data collection systems that are existing, we are not doing much to actually analyze the data to inform decision making. I think that is the key problem that we actually have. We will find that in our health systems, we are collecting a lot of data, but we are not actually using that data to inform decision making. And at the end of the day, you find we have we are duplicating efforts because we are not utilizing what is already existing. I think that is a very important aspect that we should put in place for if we want to improve our primary healthcare system. The way that we are saying, the most important thing is to utilize evidence-based, utilize our data to inform decision making, continuous data analysis. Thank you.
Thank you, Annalena. That's a very interesting point, and one that we have heard before in our chapter consultation. So I think it's definitely something that we need to think about. And it's something that has been said several times, is that we have a lot of data and a lot of resources in terms of or maybe not resources, but a lot of data available that we're not actually using that has the potential to actually be analyzed and make changes in that way. So thank you for that. I don't know if anyone else has any additions to make on that or anything else that they'd like to add to what we've spoken about today. Okay, otherwise I think we've lost a few people. Some people had some other commitments. But I'd just like to say thank you to everyone who did join and who contributed to the discussion today. If anyone is not yet a member of AfroPHC, I'd like to encourage you to visit our website, afrophc.org, and become a member. Membership is currently free. And also to go to the website and look at the other key activities that Mercy mentioned within her presentation that AfroPHC is involved in. And also, I'd just like to encourage continued engagement on our WhatsApp group. It is a forum for us to engage on the things that we discussed today. So if there are discussions that have been mentioned today or things that you think of in the upcoming weeks or days about challenges with PHC, or if you revisit the draft policy framework and feel like there are things that need clarity or any additions that you would like, you can feel free to post them on the group, and potentially we could create discussion that way around it. Otherwise, I'd just like to thank everyone for being here today, and thank you all for your additions. It's very valued, and we thank you for taking out this time for being with us this afternoon. I don't know if I have any additions from any of the other members of the AfroPHC team.
Well done, Jamie. Thank you very much for facilitating, and thanks to everyone for joining us today.
Thanks so much, Prof. Shabir. And I think that is all for today. Thank you very much everyone for joining us. And like I said, we will continue engagement on the WhatsApp group.
Bye-bye, everyone. Take care.
Everyone, bye-bye.